on assessing the practice of internal quality control in a laboratory. Now, let us think of a scenario that we often face in the lab. Just a second. I'm just trying to put this one a little. Yeah. So we have a scenario which we often face in the lab. While we are trying to release reports, we may come across a report, for example, a serum potassium, which in a patient is 2.8 millimoles per liter. Now, what is the first question that crosses our mind? Is this a correct value or is this not a correct value? Now, 2.8 could be due to the patient's condition, or is it because of some problem which we have faced in our lab? Either with the control or with the reagent or with the calibrator or with the environmental conditions or a machine, there could be n number of possibilities in the lab. And we from our end want to make sure that we do not release a report when there is a problem in the lab. So how do we get to know that this value of 2.8, which is a critically low value and needs to be informed immediately, is not because of something going wrong at our end? Right. So we need to be sure before we release that it is not normal, say 4.2 millimoles per liter, but it is actually 2.8, which is a critically low parameter. So at the lab end, what is it that daily gives us that confidence that the report that we are releasing is the correct report? And that is by regular use of an internal quality control and the statistical tools that come with it. Now, the first thing that I'd like to make clear are the two terms that we normally use for quality control. A lot of people use them interchangeably when they actually mean different. One is quality assurance and the other is quality control. Now, quality assurance encompasses the entire system. That is right from the sample taking from the doctor writing to the sample being taken, to the transportation, to the pre-analyticals, to the analyticals, the post-analyticals, the documentation, everything, which includes the entire quality system. Whereas quality control is a part of the quality assurance and is specific to the tools that we apply to measure and assess the quality of the analytical data. So this is very important that here we are, when we talk of internal quality control, we are specifically talking of the tools that will be used by us to assess the quality of the analytical data. So this is what we talk of the quality assurance cycle, which would include a pre-analytical phase, right from the sample collection, patient preparation, the personnel competency, the receipt, this assessing in the lab, transportation, quality control, and testing, which makes a part of the analytical system. Then the post-analytical, which is our reporting and our record keeping, along with our customer service safety, data management, etc., etc. Now, when we talk of internal quality, what are the factors that would affect it? There are a lot of factors which are outside the lab, starting with the doctor, the patient, the requisition, preparation, handling, etc. Now, within the lab, which we are very well connected with and which is really our responsibility, is also sample receiving, analysis, results, and reports. Of course, everything is our responsibility. But some labs do not deal with some parts of it. Most labs do deal with it. So all these things become our responsibility for the quality control. So coming specifically to internal quality control. Now, this is a part of a quality program, which we can see very well from this diagram. That the entire quality system includes the quality assurance, and part of it is the quality control. But it is actually the backbone of our labs. We run an IQC daily. And if it's a 24-hour lab, it's done 8 hourly. Most labs run it at least twice a day. So the aim of this is to get a method consistency and to also get confidence in the release of patient results. So an IQC is the best, the most effective and efficient way in detecting errors. So when we talk of quality control, what is our goal? We have a simple goal, very, very simple, and that is to evaluate and minimize analytical errors. Now, we will come to analytical errors a little later, but our aim is to minimize errors. And how do we minimize errors in the lab? Number one, by evaluating operating protocols. These protocols would be a calibration, which is done daily or at regular intervals. Maintenance. Maintenance could be daily, weekly, monthly, preventive maintenance, excuse me, which could be 6 monthly or yearly. Then the next most important thing is to access your daily performance, your daily IQC performance. And daily IQC performance is not by just looking at the controls and just signing on them, which is a lot of us do that. We see, we get a paper in front of us and we sign on it. We have to have a statistical performance and check the statistical performance. And finally, we have the periodic validation of accuracy and precision. This periodic validation could be monthly, could be 3 monthly, and this is done through the EQA or the proficiency testing. That is external quality assessment. Now, the key features of a lab's quality system. Number one is that everything must be documented. It's very important. Everything must be documented and must be documented in such a way that it is easily understood. Now, if we are got a lab in, say, the Hindi heartland, say in Uttar Pradesh, where most of the technicians understand Hindi, and we have the SOPs written in English, it is not going to help. Or it is written in maybe Tharoor's English, which is very complicated. So it has to be documented in such a way that it is very easily understood by each and every staff member. The aim is that our systems, our processes should be stable, should be reliable, and should not be dependent on one person. That if today that one person is on leave, everybody says this, we've received a sample, say for say VMA analysis, which has to be done manually. The SOP is not available, that technician is on leave, so we will wait. After 3 days, the technician will come, then we will only do the test because nobody else knows how to do it. So we have to have a system in place. And the lab has to demonstrate that there is a system in place. And how does the lab demonstrate that the system is in place? By documentation, by SOPs, by records. So all these things will help inform the assessor that we are not doing just a series of uncoordinated activities. We have a system in place which is understood by all and which is subjected to audits, external and internal, for continual improvement. Now, two terminologies which are very, very important in labs when we are working in the lab, and that is accuracy and precision. And we cannot move on to our understanding what exactly is an IQC until we understand what exactly is accuracy and precision. Now, accuracy means how well a measurement agrees with an accepted value. We have a mean value. How close is our value to that mean value? And precision is how well a series of measurements agree with each other. Now, let me give an example. Suppose we run blood control for glucose every day. The mean is, say, 100. We are getting a value of 75. So we have to see for accuracy how close is our value to the mean value. And then when we come to precision, the aim is, why do we need a precision in the lab? We have a patient who has come today with the blood glucose, say, of 350. Now, when the blood glucose level is 350, we are effectively labeling the patient as a diabetic. Now, tomorrow, when he goes to the doctor gives him medication and tells him get it checked after a week. He comes after a week and we check. Then the doctor says check after another week. We find that he's not still very well managed. So the doctor changes him to insulin. And after putting him on insulin, he says, please get your glucose checked every day for the next 1 week. Now, when the patient comes every day, if our values are not precise, we are not going to be giving a correct value. And we are not going to be giving a correct monitoring for the clinician. So it is very important that our reports be not only accurate, but also precise. Now, if we see this diagram, we see the values here. If we say that the values are acceptable, say till the red thing, the deviation is acceptable till the red colored section. So if the values are all here, then our values are accurate and precise because our values are very close to the mean value and they are all on repetition very close to each other. Now, if we see this diagram, we find that the value is inaccurate because it is far away from the target value. But the values are precise. It doesn't help us because we are still inaccurate. And if you see this diagram, we find that it is somewhat accurate because some of the values are in the yellow part and few are in the red, but they are highly imprecise because there's a lot of reproducibility error. And if we see this, we find they are completely inaccurate and imprecise. So what we are striving for in our lab is this, accurate and precise. So the ideal QC scenario in the lab should be that when we run our controls should be as close to the mean as possible. And the accepted is it should be within plus minus 2 ST. That is, the variation should be either in the plus, that is upward, or in the downward direction, but within 2 standard deviation. Now, standard deviation and mean today morning very well explained by Dr. Neeraj. So I hope you all know that, and I'm not going into details about that. But standard deviation basically tells you how much your result is deviating from the mean. And this, what we normally take in the lab is about plus minus 2 ST. So ideal situation would be this. And as we all know in the lab, we've all seen that the ideal situation does not happen very often. Then there could be a scenario where the value could be imprecise. Imprecise means there is a huge amount of scatter. Precision is not good. So there is some error that is there in our system. Inaccuracy. That we may sometimes when we are seeing our LJ charts, we might see a trend or a shift. So that will show that we have a QC scenario of inaccuracy. Or there could be a random error, that there is no pattern. Sometimes it is coming normal, sometimes it is coming very far, there is some error which we cannot, it's not showing any pattern. So when we are running a quality control, these are the 4 scenarios that we normally see in the lab. So we have to start with a QC program. We have to make a plan as to how do we move with the quality control program in the lab. So number one, which is very, very important, and we always stress, is the documentation. That we have to have our policies and procedures written. That if the control is within 2 SD, how do we proceed? If it is within 2 to 3, how do we proceed? If it is beyond 3, how do we proceed? How is the technician going to handle the out of control situations? Then assign responsibility. We have seen that when we leave any task for anybody, that it is to be done, nobody takes the responsibility. So it is very important to know who is going to run the daily control, who is going to check the daily control, who is going to review it, who is going to see their LJ charts, when are they going to see it, and how are they going to monitor. And for all this, we have to train our staff. Unless our staff knows exactly what is out, how it's a very common saying which all of us have been taught in our MBBS days, that what the mind does not know, the eye does not see. If they do not even know that this is an out of control situation, that if something is going beyond 2SD, is it a rejection or is it a warning? They will just keep repeating the controls and wasting the reagents and controls. Then what kind of control materials to buy? The control material controls also have certain specifications that they have to be as close to the matrix that we are testing, should be close to the clinical decision levels. Then what are the levels that we want? Level 1, 2, 3. Are the values, it's very important to check, are the values close to the medical decision levels or not? Is it sufficiently covering the lower level, the normal levels, the upper levels or not? Or are you finding that the levels are all towards, like this has happened with us once. We had taken a control and we found that the controls for level 1, 2, and 3 were only overlapping values of low, very low, which were not clinically significant, low, and the normal. The high levels were not covered in that. Then how to collect the data, how to set target values, how do we set the mean, how do we calculate the standard deviation, how do we make Levy-Jennings charts? These days, it's pretty simple now because most of the new auto analyzers, they do make the Levy-Jennings charts, or we have middlewares, and we also have these Unity softwares, plus, of course, the Excel systems. How to be plotting the data, how to troubleshoot these charts, and what are the corrective actions to be taken. And then again, we come back to the simple thing of documentation. Because it's very, very simple. What is not documented is not done. So this should be a mantra for all of us that what is not documented is not done. Now, every QC program will definitely face certain challenges. It's not going to be a cakewalk. It's not going to be so easy that we have decided that we are going to run a QC program, everything moves smoothly. No, what is our quality requirement? What are our targets going to be? Where do you take the accuracy from? How do you make your own lab mean? What is bias? What is total error? Where do we take all these from? How do we design our QC system? Do we run one level? Do we run two levels? What is the frequency of the level? How do we address the out of control situation? What are the rules to check? Now, if we have to be very clear on what are the appropriate rules for us. If we try and put every possible rules, we'll never move ahead. And we cannot also keep repeating our controls, our tests. We cannot even stop our tests for very long. So how do we move ahead? How do we document the outliers? And how do we coordinate our IQC and the EQA activities? Because if we are doing our internal quality control, after a month, we are going to get a report for external quality assurance. How do we connect the two? How do we coordinate for troubleshooting that what is happening to both? So these are the most common challenges that we normally face in the lab. Now, how is the IQC data monitored? Usually what happens is that a technical staff will come and bring the printout to the consultant who is very busy because he has about 1,000 odd reports to be released. And a lot of printouts today from the machine will not give a range. They will only give the value of the control that is run. So you see that there is a range. It has not been flagged at all in the printout. And you sign out there and say, yes, today's control is N. At the end of the month, when you take a look at the LJ chart, you will find that there is a shift which is going and becoming a trend. And it has gone out. And if this had been seen big at the beginning, maybe you would have been able to catch this error in time. So it is very important that we plot the control values and monitor regularly, not wait for it to happen at the end of the month. Monitor at regular intervals to see the precision and the accuracy of the repeated measurements. So if we are running our control values and we are seeing something here, and then we suddenly seeing that there is, if we were seeing at the end of the month, we would have come and seen here, and we would have missed this happening here. But if we had checked regularly and monitored, we would have seen that right here there is a shift. It has gone here. And then it's shifting and going up here slowly, slowly here. So this was the time to pick it up and catch that what is the error? Has anything changed around this time? So it is very important that we review charts at defined intervals, take the necessary action, document the action here, and prevent a situation like this happening. Now, when we are sitting in the lab and when we are talking of internal quality control, we talk a lot of errors. We have to stop errors, we have to address these errors, and how will we address these errors? What are the analytical errors? What do you mean by analytical errors? So errors can be three types. One is random error. Then we have systematic errors. Random errors usually talk of imprecision. Systematic errors are the ones that tell us about inaccuracy, whether there is a shift or a trend away from the lab mean. And third, of course, are major blunders, which are just blunders and cannot be explained by anything. So, random error is an error which does not follow a specific pattern. It just happens, and it is an inconsistent, irregular kind of a thing which might just happen one day, may not happen the next day. There could be anything which could be leading to a random error. Few examples are given here. There could be bubbles in the reagent. There could be a fresh reagent has been put, it has not been inadequately mixed, or sudden fluctuation in temperature, fluctuation in your electrical supply of the machine, which gives a sudden jerk or a jolt. Clot in a sample, in one particular sample. It may not happen in every sample. Transcriptional error or an incorrect reconstitution of a QC material. All these are random errors which do not show a specific pattern. Whereas we have something called as a systematic error. Systematic error may be due to, they will show a shift or a trend. That is, they will show a specific pattern that is happening. And that would be due to some error in your system, in the process. That could be, for example, change in a reagent lot or a calibrator lot. So till the calibrator or the reagent is being used, that error will persist. The reagent is being improperly prepared. Now here what it is, that there is, the SOP was not there, the documentation was not there, the technician who normally prepares reagents was on leave, somebody else did in their place, and the reagent was reconstituted with, instead of 5 ml, they did it with 4.5 ml. So now when the reagent goes on there, till the lab is using that particular reagent, there will be a shift from the mean. If there is deterioration of the reagents or calibrators or control, storage, that every night they are being stored in a fridge which is not maintaining the adequate temperature. Change, so all these change in temperature, change in the volume, change, deterioration of the lamp, change in the procedure. One operator was doing it, they did not know that there was a pre-sample treatment to be done, and they just put the sample directly in the machine, or a debris or anything blocking the reagent probe. So all these errors will show you a trend, that is a long time shift from the mean. So this is called a systematic error. So a random error would be an inconsistent change which would lead to a change in precision, a scattered SD, whereas a systematic error would be a consistent change and would lead to a bias and would be due to a specific cause. Now, why do we need to understand the errors? Why it's so important to realize that there is an error in the lab? What kind of error is it? Is it random or is it systematic? And how do we determine that this particular error is a systematic error or a random error? Because we are getting a control that is out. Just by looking at a control that is out or looking at a patient sample which is not correlating with previous samples, you can't say that what is the cause of the error. Is this a random error or is it a systematic error? So how do we find out that these errors are random or systematic? For that, Mr. Westgard came to our help, came to our rescue, and he designed certain rules, which are called the Westgard rules. And these Westgard rules help us to detect errors. And by detecting errors, it also helps to reduce cost while maintaining quality and helps to reduce false rejection without compromising on quality. So what are these Westgard rules? Now, what he has done is he has designed a whole lot of rules. There are a lot of rules. Now, we have to see in our lab, as per our situation, what are the rules we are going to follow and how, and document it. So there are different rules that have been given out. Like number one rule is a 1-3S rule. 1-3S rule says that there is one value of the control which is beyond 3SD and which needs to be rejected. So this will flag your precision because your mean is here and your value is far away from the mean. So if you go and check the LJ chart immediately, once the control is out, you see that the patient results are not correlating. You check the control and you find that the control is out. So then if you go on to the Westgard LJ chart, and LJ chart, you see that here the value is on 3SD. So at once you get to know that this is precision which is being flagged. And so it may be a random error. Let's check what it is. Because up till now we were within 2SD. Similarly, there is a rule which is called the 2-2S rule, where two consecutive controls are being out beyond 2SD. 2SD, two consecutive controls. They could be minus 2SD or plus 2SD, beyond these 2SD rules. So these two will uh, tell you how to flag the precision. Here is another one that flags precision, which is R4S rule, and that is minus 2S and plus 2S. So R4S is that the difference between the maximum and the minimum QC value exceeds 4 standard deviations. That means one time the control was run, it was at plus 2, and the other time it was minus 2. So there is a 4 standard deviation difference between two control values. So all these will tell you that precision, there is something wrong. Then we come to a rule which is called the 2-2S rule, that two consecutive rules are outside the same SD. Or 4 times it may be outside the same SD. Or there could be something like a 10S rule, which is also called the 10X rule, that there is a consistent bias here. If you see the 10X rule. So we find that when we have these Westgard rules, there is something called as a, if we have 1 2s, that could be a false rejection, that in all the controls you've run, only once that one control has been outside 1 2s. So that may just be as a warning rule. Whereas if we have 1 3s and R4s, then these are random errors. And if we have something called a systematic error, that will be 2 2s, 4 1s, or 10x. Because these will show us uh, that there is a trend or a shift. So this is very important. This is how, when we see the error, we can get to know that this is a random error or this is a systematic error. So when we see the errors, it's a lot of problem and we have to fix it, and fix it soon. We have to fix it immediately before we release reports. So when we see a control and it is out of our defined values, what do we do? Three possibilities. Either we ignore and continue testing, which is not a good idea, which is not a good thing to do. Repeat the controls and keep repeating them and keep repeating them till they are within range. And third is to, which is the right way, is to stop testing and investigate the cause. Now, I would agree that there is no perfect way to troubleshoot. So, what do we do? Normally, the reaction of most of our technical staff would be just to rerun the control, or to control is still out, let's recalibrate. Now, it may still lead to a control out. And after recalibration, if it's still out, you are stuck with another error. Now, what to do? So, we have to stop our three bad habits. That is, repeat the control, try a new control, and recalibrate. And develop certain good habits. And that good habit mainly is to find out and solve our problems. So we have to solve the problem. One is, quickly go to check your control again, check the LJ chart and see, is it a random error or is it a systematic error? If it is a random error, what could be the reason? If it's a systematic error, what could be the reason? So good habit two would be to relate the type of error to the cause, and then see if any recent changes have taken place and that is why this has happened. Then verify the solution. Check, yes, this is the solution, and then now we are getting the right results, and then document it in your kappa thing. So as soon as the important steps to follow, as soon as you check an out of control situation, that would be to stop testing the sample immediately, to stop the release of reports. Then search for recent events after finding out what is the cause of, what is the type of error, what is the cause of error. And then follow the troubleshooting SOP, and then do the root cause analysis and do kappa. So how do we check? We check for a control, we check for a reagent, we check for a calibrator. And if all these are no, we keep each lab. This is just a random example. The lab must check their own system, their own process, and make their own process flowchart. That if we check the control seems all right, nothing is wrong with it. Then check the reagent. If there is a problem with the reagent or not, any new reagent has been done, or calibrator, the instrument or the environment. Now, if we check the control, we check all this. That was it a correct material used? Was the control expired or not? Has it been stored properly? Has it been reconstituted properly? Or did the technician take out the control, left it, and suddenly after 2 3 hours, they realized they haven't run the control, so they came to run it. Or conversely, They took the control out of the thing and it had to be brought to room temperature, but they didn't bother waiting because they were going off duty. So he quickly took it and without properly thawing the control was put in the machine. So if nothing is wrong with the control, then we check the reagent. Is it the correct reagent? Is it an expired reagent? Has it been reconstituted properly? Was the lot-to-lot verification okay? Was it prepared properly? All these things, was it stored properly? If the reagent is all right, then we check the calibrator. We'll check the lot of the calibrator, preparation, reconstitution, storage, expiry. All these things have to be checked. Then we move to the instrument. Maintenance of the instrument. Any leak, any probe blockage, any syringe leakage, any errors on the status monitor. So all these have to be checked. Environmental conditions. So I'm sure one of these you will find out that one of these is that if nothing is available, then of course you can't pinpoint anything and it's only a one-time error, then it could be a random error. So let's take a few examples. Now, I'm going to give you an example that an IQC aliquot was taken out from the freezer by the night technician and kept in the analyzer to run without thawing and mixing, the example I just gave. And then they suddenly saw the time is up and he has to go. So he quickly picked up the bag and left. The morning technician came 5 minutes later. He did not meet the night technician and he said, okay, let me check. The control has been put. Let me run. The values came much lower or the values came much higher. Why? Because there is improper mixing of the control. It had been frozen. We do not know whether the thawing had left any kind of water on top and the control there. It has to be properly thawed and properly mixed and then put in the machine. So it resulted in an IQC which was not correct, not accurate at all. So this is the example that you see a specific pattern in the IQC. And if you're seeing that daily, that there is something going wrong and every morning you're finding that this control is out, but the evening technician, when they're running, it is absolutely all right because he's not going off duty. So what he's doing is he is taking it out, correctly thawing it, mixing it properly, and then running the control. So the consultant checks and finds out that every morning when these people are on duty, morning control for this parameter is out, but the evening control is in. So the specific pattern when he checked, he found that there was the handling of the control material which was going wrong and which needed to be corrected. So this is an example of how there could be different errors occurring in your IQC control and how to troubleshoot. Then this is another example where the doctor said that he got a triglyceride value of a known patient who'd been with him for some time and who had been coming to him and under medication. And he found that the patient was under medication, his triglyceride levels were well controlled. But today, the value is much higher and is not correlating with the previous values at all, despite there being no change in medication and the patient being compliant with the medicines. So he rang up the lab and told the lab that please check. So the consultant said, okay, let's check the LJ charts. And when he checked the LJ charts, he found that there was an upward trend in the graph for the last week. That the control data was at 2 ST range. Before this, the trend was that it was occurring within the 1 ST range, that the control range was within 1 ST, very close to the mean. But today when he checked, he found that it was at 2 ST, plus 2 ST. That is why the values were going higher side. So when he checked, he said, okay, show me the calibration. When was this last calibrated? And he found that 10 days ago, the calibration was done for a new kit. And ever since, there was an increasing trend in the control values. So all the controls from very near the mean were going on the higher side. There was an increasing value. So from that day onwards, the TG values were showing an increasing trend on your LJ chart. So he said, okay, 10 days ago until today, there has been an increase in the value. There's a trend. So show me what the calibration was. How was the calibration done? What was the calibration factor? And they found that the calibration factor done 10 days ago was much higher than the previous calibration factors. And that is why the results were coming on the higher side. So it was noticed, then the consultant said, who's checking it? Who's monitoring it? And it was found that the lab staff was only looking at the printout which was showing the control value of that day. So they would see the control value there and they would say that yes, today's value, there is no error flag next to it. They didn't check the range. They just saw that there is a value, there is no error flag to it, so it is fine, and then carry on, keep running the controls. But if they had been checking the LJ chart at regular intervals, they would have noticed that there is a trend. Since the last 10 days, there was a trend, and today the values have reached 2ST. So the lesson we learn here is that proper validation of LJ charts at regular intervals, proper monitoring and reviewing of LJ charts at regular intervals will help us to identify the errors earlier and will prevent a clinician calling the lab and telling the lab that, listen, your results are not right, which is something we all want to avoid. Now I'll talk about a third scenario. This scenario was that lot to lot verification was done. There were two new lots of creatinine reagents were there. So they were analyzed and two IQC aliquots were taken for them to check the controls. When the controls were checked, both were coming all right. So a lot to lot comparison was performed. And then 20, I mean, these people did 20 patient sample. Not every lab does it, but a particular lab ran 20 patient sample, even if two are run. They found that the mean for lot B was 1.73 and lot A was 1.5. And they were both within the range which the lab had put. But so when the IQC was checked, it was all coming all right. But when they did the percent difference, they found that the difference was coming to 15, whereas their acceptance value they had put at 10%. So this is another scenario where just looking at the control without seeing how close it is to the mean, without checking for accuracy and precision, sometimes there could also be a failure of the IQC. So this significant reagent lot shift could be due to any reason, could be a problem in the transportation of the reagent, a storage of the reagent. Maybe the company had changed the preservative or something. So I'm just giving an example of another scenario where if you're just looking at the range without checking whether there is what an error it is, whether there's a shift or a trend, could also lead to an error being missed. Now, these are just some examples of LJ charts. Now, in the morning lecture, Dr. Neeraj Jain had also told us about the LJ charts. So this is just an example of a chart, which is a very good LJ chart, whereas the mean, this is the mean. This is the ST, one ST range. These are two ST ranges. And these are three ST ranges. So normally it is that the lab has defined that 2ST is what we will take as within run, and anything beyond 2ST is a rejection. So here is what the LJ chart shows us. It will tell you the date and it will tell us the time. It gives us the result. It gives you the reagent lot number and it gives the LJ chart, which has been the control, how close it has been to the mean. So we find here that this is a very good one where there is very close to the mean, where there is a variation which is equal, sometimes on the left, sometimes on the right, plus minus is happening at regular intervals. And here we find that it's been one control run daily, and the control is doing very well. It is very stable. So this is a LJ chart, which is where the analyte is performing well. Now we come to another LJ chart, which is also, well, quite all right, because there is a variation on both sides and it's close to the mean. Now here we have an LJ chart where we find that all the values are on one side of the mean. Lucky for the lab that they're within 1 SD, but there is a bias. There is a shift from this side to this side. Here is a shift. So the lab needs to check what is wrong here. What is in this thing that is giving this bias? Here again is an LJ chart where they are all on one side, very close to the mean. Then there is one, but only to 1 SD, but there is. So we have to check here whether the bias is clinically significant or not. Now this is one LJ chart which is showing a lot of variations. You are getting a flag here. There is one on 1 SD, then there is a one on 2 SD, then it comes here, then here, then again here. So here there is something that has happened where they have all shifted here. What has happened here for the lab to investigate? Now here see here, see here. There has been a lot of running of controls. Now, has the lab done any root cause analysis? That if it has shifted here, why has there been such a sudden shift here? And then it has been on this side only. Here, I'll give you another example where there is all the values are on the plus 1 to 2 SD here, coming here, 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 here. And then suddenly here, what has happened which has made this shift here? And then this trend is towards the lower side, minus 1 SD. Again, check how many times has the lab run the controls? What have they done? Have they done something here? Because 17th they ran, the control was out, and then what has been done to run it again, and after which this shift has happened. Here is another example where they're completely out here. So this is not a very precise or an accurate one here. This is a horrifying LJ chart actually. This is the nightmare of all of us in the lab. How now please see here what the technician has done. On 5th, he has run the control here, which has come absolutely here. Then it is like an R4S beyond even that shifted right here. Then he has run the control again on 5th and here. Now here something was done then, and the trend starts again, comes near to 1 SD, comes here again and comes here. So this is what the lab has to investigate, that what was done. Was the reagent changed here? Was the calibration done? Was the control changed? If there was any change, what was the reason for the change and what was the root cause that was happening? Because once it was done here, again the control is out here. So here there is something wrong with the methodology or the reagent. So this requires a proper root cause analysis. Again, one of those pretty bad LJ charts which have to do a complete root cause analysis and a documentation of the corrective action taken and verification of the corrective action, which is very, very important after such an LJ chart. Because on 5th at 12:46 ran, it was beyond 2 SD, almost 3 SD. It was then at again it was run uh, at, after 12 it was run at 2. It came to minus 2 ST. Then it was run at 233. This again those bad habits that I spoke about. It went beyond 3 ST. Then what was done that is just about managed to come in, but again it's on the higher side here. And then again it goes straight to the other side here. So there is a lot of flagging of inaccuracy and precision here. Again, LJ chart, which is pretty horrifying. Total lack of accuracy here. Now, sometimes what happens is that we are using a very small analyzer, a semi-auto analyzer, or a machine for, say, A1C, where the machine does not give an LJ chart. What do we do in those circumstances? Easiest way is to put the values in Excel and plot it ourselves manually, so that at least we get to know the idea of how our control and how our IQC is performing. So we can make the mean here, we can make 1 SD, 2 SD values here, plot them on Excel and get a perfect graph. So here we have the date, we have here the values, and we know exactly how our analyte has been performing daily. And we also get to know when it is out here or here, and what corrective action was taken or not taken. Now, there is something known as a total allowable error, which most of us are not doing right now, but it is what is going to be the future, in which we define the total allowable error that is given already by these Nikos, Carmen, or CLIA, or other regulatory bodies, and calculate the sigma. Sigma is calculated by total allowable error minus bias upon CV. And once we calculate the sigma, we follow these rules. These can also help in cutting down the number of quality IQCs that we are running, the number of times we are running the controls. And anything less than 3 is considered unacceptable. Anything beyond 6 is considered to be working very well. And a total allowable error we normally take from CLIA guidelines or the Ricos-Carmen guidelines, which would be for like minimum desirable or optimum, and each lab to decide whether they would like to start with the minimum and slowly move to desirable and then to optimum. And these are the values which it gives uh, for imprecision here, for bias and the total allowable error. So this was just a very brief overview of what a total allowable error is and how this can also be incorporated into our daily QC routine by calculating sigma and trying to reduce the number of controls. If our analyte is giving anything beyond 4 or 5, that means the process is quite stable, the analyte is stable. We can cut down on the number of runs, but anything less than 3 is totally unacceptable. So to summarize, that when we talk of quality assurance, we talk of IQC and EQUAS. We must perform our daily IQC as per our SOP. And it's very important that our SOP gives everything step by step by step. A root cause analysis and a corrective action is a must. Documentation is a must. And all tests should be stopped until we are very, very confident that whatever we are releasing is absolutely correct. So our take-home message is that our laboratory investigations are one of the major contributors to most clinical decisions. Who decides that a patient is diabetic? We people. Who decides that there is an acute kidney injury? We people. Who decides whether a patient is in actually a myocardial infarction or not? So it is our investigations which help to make the clinical decision. And internal quality control is one statistical way, a very objective way to evaluate our analytical process. And hence, it gives us confidence in our lab results, helps us to tell the clinician that yes, we are correct and gives credibility to the laboratory. So thank you very much for your patient listening.